So my takeaway from the 2020 data at ASCO regarding the Mindact trial is that we now have extended follow-up nearly 9 years for these patients. And looking at the primary endpoint of the study of 5 years distant metastatic-free survival for patients with clinically high risk, but genomically mammoprint low-risk patients, that these patients still did very well without chemotherapy. The difference in patients went from 1.5% to 0.9%, so it's even getting better. That we really can de-escalate therapy in these patients. There's really no benefit to chemotherapy in women that are clinically high risk, mammoprint low risk, including those with even positive lymph nodes. With the Mindact data regarding women under the age of 50, it was very interesting that we did see this approximately 5% benefit from chemotherapy at this 8-year mark, nearly 9 years. This difference, can be explained probably in part to ovarian suppression. So that's something that we have had ongoing discussions with our patients due to the soft text data with ovarian suppression and endocrine therapy in premenopausal women. And I think that's a discussion that we have to have when we receive the results of the mammoprint, knowing that there may be this difference in distant metastatic-free survival in younger women, but we may be able to attribute some or part of that at least to ovarian suppression. So I think we're going to be looking at even more aggressive ovarian suppression and endocrine therapy in our premenopausal women, but we will have to have, a shared decision making with the patients. So we've seen multiple studies come out at ASCO 2020 regarding mammoprint and blueprint. So I think the right patient to order mammoprint and blueprint on is actually a significant amount of patients. So we know from the Mindact data are ordering on patients who have clinically high risk estrogen receptor positive HER2 negative breast cancer can provide some clarity on chemotherapy and de-escalating chemotherapy usage. I think also the data on HER2 positive disease, the CAP guidelines that we use for HER2 positivity have evolved over time, but there's still a lot of patients where it's questionable if they're really HER2 positive or if they're HER2 equivocal. And we can see that the HER2 data that Agendia has presented through blueprint testing has really clarified who is exactly HER2 positive genomically. And I think that can help us with discussions with patient and even some treatment decisions. Also, patients with ER positive breast cancers that are even low risk, there is some data for the de-escalation, maybe even of endocrine therapy. And that's retrospective data that still needs to have more data presented before we can use that clinically, but that's also very helpful. The last group are patients who are ER positive but have a low positivity. So patients where maybe they're 20% or 50% ER positive, and you're checking them to see if they need chemotherapy based on their ER positivity. We've seen a lot of these patients coming back as basal type on the molecular genomics from the blueprint, right? And that may change some of our chemotherapy choices or some of maybe our endocrine choices, knowing the genomics on that patient. So it's a pretty broad range of patients where the mammoprint and the blueprint can actually be very helpful. There's been some great presentations this year at ASCO 2020. I think the areas where I've seen the most exciting data has been in the metastatic breast cancer area, especially patients with ER positive breast cancer and HER2 positive breast cancer with novel therapeutic agents. We're starting to see some longer follow-up data for these patients, especially patients who are heavily pretreated, who are having these extended intervals in their progression-free survival. So very exciting that some of these novel therapeutics we've been able to use clinically over the last year or two are really starting to make a difference.